Okay, I'm going to turn it over to Fran.
Okay, well, good evening, everyone. Welcome. I'm Fran Buczynski, and Helen Hathi Rios and myself are co-chairs of the Healthcare Subcommittee of Social Justice Action, the sponsor of tonight's event. We're here tonight to talk about affordable, accessible healthcare for all. The Catholic social justice tradition teaches us that healthcare is a human right, not a privilege. We are pleased to have Dr. Oliver Fein with us this evening to share with us how that teaching can be implemented here in the United States. Dr. Fein is a professor of clinical medicine and clinical public health at Weill Cornell Medical College, a past president of Physicians for a National Health Program, and chair of the New York Metro chapter of Physicians for a National Health Program. As exemplified by his work, Dr. Fein shares the view that healthcare is a right. Tonight, he will discuss how and why publicly funded single-payer health insurance system can deliver high-quality, equitably accessible healthcare to all, explain how it works, and why it would improve health equity. Tonight's presentation will consist of about 1/2 hour of a slide presentation followed by a question period. Welcome, Dr. Fein. It's a pleasure to have you with us this evening.
Well, thank you so much for that generous introduction. Yes, indeed, we will be talking about an improved Medicare for all. The healthcare really is and should be a human right. So I just have a few disclosures to make. I have no relevant financial relationships with commercial interests that shape this talk, but I am, as was mentioned, the chair of the New York Metro chapter of Physicians for a National Health Program. This is a nonprofit educational and advocacy organization, but I have received absolutely no financial compensation from that organization. If anything, I've donated money to it. So, what are we going to talk about this evening? First, why we need a single-payer healthcare reform because of the uninsurance, underinsurance, and poor outcomes and high cost of our system. Briefly mention the impact of COVID on U.S. healthcare, and really devote a lot of our time to talking about single-payer healthcare reform, both on the national level and also a state-based proposal, the New York Health Act here in New York State. So, starting with the problems with our present system, uninsurance and structural racism. And what you see here is that back before 1940, there was virtually no insurance in the United States for healthcare, even private insurance. It turns out that in 1936, an entity was created called BC, Blue Cross. It was a nonprofit insurance company that only covered hospital care. And it was extremely popular in the growing union movement at that time. But then when we entered the Second World War, unions were not permitted to bargain for benefits, wages rather, but they were allowed to bargain for benefits. And healthcare was one of the major ones. So I think this is the accident of history in which health insurance gets linked to employment in the United States. There is no other industrialized country in the world that has that provision. Then as we emerge from the war in 1946, another entity is formed called BS, Blue Shield. And how does it differ from Blue Cross? It covers, in fact, outpatient care, doctor visits, and no medications, however. And then we see the decline in the uninsured as people get insurance through their employment. And then this precipitous decline here in 1965. Why is that? Yes, the creation of Medicare and Medicaid. And then from the mid 1970s up to 2009, there is about 1 million more uninsured in the United States. And in 2010 rather, the Affordable Care Act is passed by Congress. And then there's a gradual decline here because the Supreme Court has to rule on the constitutionality of the ACA. Can, in fact, government force people to buy health insurance? And the Supreme Court finally says yes. And we see again this decline. But frankly, we never got to a place where we were less than 28 million uninsured. So, frankly, we have a problem still of uninsurance in the United States. And the other tragic thing about this is that the lack of insurance is greatest among Black people, here to about 10%, Hispanics close to 18%, and Native Americans over 20%. So there is a real problem in terms of, again, access to insurance. And finally, there is this problem of structural racism in which Black and Latinx serving hospitals are ones that have less funding for buildings and equipment. And here you see the comparison in terms of total assets of the Black serving hospitals, the Latinx serving hospitals, compared to the mainly white serving hospitals. So we have some real problems with structural racism, but I think that's only a partial problem. We are suffering from an epidemic of underinsurance. Here, what you see is that the average annual premium for family coverage is now over $21,000. And if you had an individual policy, it would be $7,470. And if you look at what's happened in terms of the cost of insurance since 1999, what you see here is that insurance has gone up 224%, whereas the employee's contribution to that insurance has gone up 270%, at the same time as wages have only gone up 64%, and inflation has eaten away at 47% of those earnings. We are really increasingly underinsured. And here what you see are the rising deductibles. This is the amount of money you have to put out of pocket before health insurance kicks in. On average, that's $1,500. But if you work for a small company, it's going to be over $2,000 because it can't negotiate lower prices with the insurance company. And if you work for a large company that can do that, it will be roughly $1,200. And many families just can't afford this kind of out-of-pocket cost, right? What you see here is that, roughly half of all families, and these are non-poor families, in terms of the liquid assets that they have, they just don't have that $2,500 that they might have to put out of pocket for a deductible. And if they have no health insurance, it's 81% of such families. And then when you get to the out-of-pocket limits, it's close to 90% of people that can't afford those. Little wonder that 2/3 of all bankruptcies in the United States are due to medical bills or illness related to the loss of work, at which time somebody loses their health insurance. So underinsurance and uninsurance, frankly, I'd say lead to poor outcomes. And what you see here as that 38,000 deaths during 2019 were due to uninsurance. And in Texas, the state that has the highest percent of uninsured, you had the highest number of excess deaths. And when you look at life expectancy and compare us to the other industrialized nations, what you find is that we have the lowest life expectancy. And then, in terms of infant mortality, we have one of the highest, close to 6 deaths in the first year of life per 1,000 live births, more than twice that in Sweden. In terms of maternal mortality, we have 26 deaths per 100,000 live births in the United States. And frankly, that's the mother dies, mind you, probably close to 12 to 13 times what you have in Australia. And frankly, this is increasing, it's not decreasing. So if you look here in the year 2000, it was 18.8 maternal deaths. In 2014, it had gone up to 23 maternal deaths per 100,000 live births. And in Texas, it had almost doubled. And finally, there's the high cost of care in the United States. And if you look at this back here in 1980, we were in the pack of industrialized nations. We were the most expensive or one of the most expensive. But since then, the costs of care in the United States have just escalated so that we are now close to twice what it costs in other industrialized nations, in spite of the fact that those countries offer universal coverage. Everyone has health insurance. Well, why is this? Well, maybe it's because, our care is, so expensive because people spend a lot of time in the hospital. But what you see here in this diagram is that we have the shortest number of days per person per year, the fewest number of days compared to these other industrialized countries. Well, maybe that's because we do some very good outpatient care and people see their doctor. But look at this, we have the lowest number of visits per doctor, close to the lowest. Compared to, look at this, Japan, 12 visits to the doctor every year. Well, maybe it's because we have too many old people in the United States. But what you see here is that we have the lowest percentage of the population, that is over 64 compared to all the other industrialized nations. Well, maybe it's because we smoke too much in the United States, but actually we've done pretty well in terms of smoking. And we're half that, the percent of population over 15 who smoke daily in France. Well, maybe we pay our doctors too much. But the interesting thing on this chart that you see is that in terms of specialists, our average compensation is actually lower than Australia and the Netherlands. And in terms of primary care, we don't do so badly, but we still, I think, are not overpaying our doctors. Well, I think this slide begins to get at an explanation. Here you see the percent of doctors and how they've grown in the United States in the yellow. But what's happened is this growth in the number of administrators and managers, really out of sight. And the reason for that is that our insurance overhead has grown to 842, dollars per capita, compared to Canada, Switzerland and France, where the amount of money to administer the insurance is much, much less. And then on the provider side, that is to say, doctors and hospitals, we have, again, the highest percent of administrative costs. 25% of all US hospital spending consists of administrative costs, including the salaries for staff who handle coding and billing. Twice what it is in single payer. And this data just is out of sight, right? Here's the health insurance company CEOs, and Mark Bertolini of Aetna was getting $159,000 per day today. That's what he'll earn tomorrow and every working day thereafter. This is ridiculous overhead for insurance in the United States. So these are the four, I think, really embarrassing problems that we have. And the problem is with COVID-19, each of them has been made worse. In terms of uninsurance, the uninsured have increased since many lost jobs. And when you lose your job in this country, if it had health insurance, you would lose your health insurance as well. And underinsurance is likely to see an increase, with private insurance companies questioning whether they should pay for vaccines and testing after the government stops paying for it in this present period. In terms of poor outcomes, because of the lack of global budgeting, our hospitals ended up with shortages of PPE, testing shortages, and ventilator shortages. And finally, in terms of structural racism, hospitals that serve vulnerable communities, both urban and rural, are actually closing because of a lack of revenue due to COVID-19. So what can we do about this? Well, I'd say that single payer addresses these US healthcare system problems. It will, if it were implemented, make healthcare a human right. So what is this thing, single payer? Well, here's the physician's proposal from Physicians for a National Health Program. It is universal coverage with automatic enrollment. If you are a resident of the United States, that means even if you are undocumented, you should be covered by health insurance. Well, let's say you go to an emergency room because you have an emergent problem. They do their wallet biopsy on you and they find that you don't have any insurance. Well, let's sign you up right here for the National Health Insurance Program. You deserve that. Is there any private insurance company that would ever sign you up in the emergency room of a hospital? No way. There would be low administrative costs because it's a single payer system, and we'll describe that in more detail in the next slides. Comprehensive coverage without co-payments and deductibles, no financial barriers to access to care, maximum choice of doctor, nurse practitioner, or hospital, improved quality through nationwide health information technology. One of our big problems today in this country is that each of the private health insurance companies keeps a lot of their data, particularly mortality data, confidential. Why? Because they're worried they won't be able to sell their policies. We need a national information technology. Expanded primary care and public health, lower drug prices. Which entity in this country gets the lowest price on drugs? Anyone know? Well, it's the Veterans Administration, because it can negotiate with the pharmaceutical industry for prices. So finally, this would be a publicly funded, but frankly, privately delivered system, something like Medicare. The Cornell students tell me I should call this Medicare 2.0. So what are the constituencies of it? Well, first, improved Medicare for all would be fair public funding. You would create a trust fund for healthcare that was separate on the federal level from the military budget and all other budgets. You would transfer to that trust fund what the employer is presently contributing for the premiums of private health insurance. And hopefully, if single payer really worked, that amount might actually go down for the employer. Develop a graduated employee contribution based on income, the amount of money taken out of your check to pay for health insurance, and a tax on unearned income, such as stocks and bonds, maybe even rent. But no private health insurance premiums. Why? Because they are so regressive. The president of the company pays the same health insurance premium as her or his secretary. That makes no sense. And there would be no increase in overall costs in terms of health spending because of the administrative savings. So let's see where those savings come from. The low administrative costs and profit are really something that you see in the Medicare program. All economists agree it's about 2 or 3% of the dollars collected by Medicare pay for administrators and, essentially billing and coding and things like that. That means that 97 to 98% of the dollars collected go to pay hospitals, doctors, prescription drugs. Private insurance has an administrative cost of about 16, and some companies up to 30%. In this study, in the Annals of Internal Medicine, which is in fact a peer-reviewed journal, it is proven that about $500 billion could be saved by converting from our for-profit private health insurance to a Medicare for all or single payer program. How would providers be reimbursed? This is still not clear in the legislation, but I think the argument would be greatly in favor of global budgeting hospitals, giving them a fixed amount of money based on their expenses the year before, and having all capital funding go through a process whereby the need for it is justified. Physicians, dentists, nurse practitioners, and social workers would probably be paid on a fee-for-service basis, the way they are in the Medicare program today, but it is possible to explore some hourly reimbursement approaches. But the major thing we would advocate is that hospitals, nursing homes, dialysis centers should become non-profit. And an improved Medicare for all. Why do we say improved? Because Medicare is an imperfect program. Seniors pay premiums for Part B and Part D of the Medicare program. That's again a financial barrier. Coverage does not include dentistry, hearing aids, ophthalmology, long-term care, probably in part because this was passed in 1965, but really now we need these benefits covered as well. And Medicare was prohibited by law when Part D was passed in 2003 to negotiate with drug companies for prices. And finally, Medicare has a Part C, Medicare Plus Choice, now called Medicare Advantage, which allows private health insurance to manage your Medicare benefit, a real problem, it seems to me. So finally, Medicare for All would be a nonprofit private delivery system under local control. This is not socialized medicine. Why not? Well, in socialized medicines, doctors are salaried by government. That's what happens in the UK, in the National Health Service. And hospitals are not owned by government, as they are in the UK. This is publicly funded and a privately delivered partnership. And yes, we have two bills in Congress. The first put forward by Pramila Jayapal from Seattle, called HR 1384. This bill will probably be reintroduced to Congress, could be even next week. And it has all the principles that we've described: universal, comprehensive, choice of doctor and hospital, no co-pays or deductibles, funded through progressive taxes, and cost-effective. And yes, there is a Senate bill, and guess who put it forward but Bernie Sanders. And he has 16 co-sponsors for 1804, with all of the same principles that I've outlined previously. And if you go out and you ask people, do you favor expanded, universal, Medicare for all? What you find is that, if you ask all adults, more than a majority favor this approach. And if those adults say they're Democrats, it's up to 81% that favor Medicare for all. And independents, 60%, and even 30% of Republicans. This is a popular program, and we need the courage and boldness of legislators and president, frankly, to advocate for Medicare for all. Okay, but you say, look, Biden has said he's not going to do it. He doesn't agree with it yet. He wants to expand the ACA. He wants to potentially offer what we call a public option. So maybe we should do something on the state level. This is what happened in Canada. Saskatchewan as a province introduced single-payer health insurance. And within 5 to 10 years, the rest of Canada decided that was the way to go. So we do have the New York Health Act, which has all the benefits that I've described: comprehensive primary care, preventive mental health care, inpatient and outpatient hospital care, prescription drugs and medical devices covered, explicit mention, because we didn't want people who are on Medicare to realize that they're going to get expanded benefits: dental, vision, hearing aid, even long-term care, both in the nursing homes and at home. Free choice of doctor and hospital, and kind of a unique proposal by Richard Godfrey, chair of the Health Committee, to hire people to be care coordinators, to assist in the navigation of the system. Our system is sometimes so complicated, it helps to have somebody who is a care finder, not, it should be said, a gatekeeper. With progressive financing, federal funds, Medicare, Medicaid, CHIP, the ACA funds would all go into a state healthcare trust fund. Progressive graduated payroll tax, both progressive for the employer and for the employee. A graduated tax on non-payroll or investment income. An explicit mention that New York Health will pay for your Part B and Part D premium in the Medicare program. And New York Health would also pay for the county and New York City share of the Medicaid program. And yet it will cost less than we're now spending. How does that happen? Well, here you see it, 2% overhead costs in the Medicare program, anywhere from 13 to 17% costs in private health insurance. Here's a study done by the Rand Corporation, no left-wing corporation, by the way, which showed that indeed there would be reduced insurance administrative costs of about 6.5%, worth $20 billion, reduced physician and hospital administrative costs. They wouldn't have to have all those billers and coders, about $16 billion, bulk purchasing of drugs and devices, being able to negotiate for the New York population, which is not small, with the pharmaceutical industry, $18 billion. So a total of $55 billion of savings. And yes, things are going to cost more if you cover everyone, eliminating the copays and the deductibles. They estimated it would cost about $17 billion. And the New York Health Act talks in terms of enhancing physician fees, particularly for Medicaid patients, because physicians are paid very poorly if they care for the poor. And that would be an increased cost of $25 billion. And what you see here is a net savings really of close to $29 billion at 9.4%. Very impressive. And New York Health can control future costs probably better than private health insurance, as you can see in this graph, where the private health insurance is in this orange line, and Medicare and Medicaid in the lower blue and green lines. And here you see an estimate that of how it might work. People who earn incomes less than $25,000 would not have to contribute anything in terms of taxes into the trust fund. And then it would go up so that people with $50,000 would be paying roughly 5.6%, uh, out of their paycheck, it would be about $565. The employer would be paying $2,280. Again, much smaller amount than they presently pay. And as the incomes go up, the percentages go up as well. And here you see, that we indeed have Richard Godfrey, the chair of the Health Committee, who's gotten this bill passed in the Assembly in 2015, 16, and 17, and at a 2-to-1 margin. And now that we have Democrats controlling the New York State Senate, we have 31 co-sponsors, not quite the number that we need. We need at least 32 and probably just a bit more for the margin. And the benefits are all what we've described so far. We really do, it seems to me, have a chance to pass this. The New York Health Act has surged with the impact of COVID. It passed the Assembly, as I said, 87-38 in 2019, which was the last time it was voted on. We had 31 senators in 2019. The Democrats actually got control of the Senate in 2019 with 32 votes, but one of those Democrats refused to vote for the New York Health Act. But now, after the November election, we've got 43 Democratic senators. We have a chance to pass this bill in New York. And then the question will be, what will Governor Cuomo do with it? So what's next? Well, there's going to be a lobby day on March 23rd. If you're interested, you could come to the preparation forum March 9th. Those will be advertised on the New York Metro PNHP website, so you can get more information about them. These are going to be virtual lobby days, kind of unique, but we did one last year that was quite successful. More attention from the media, visible support from unions and community groups, but increasing attacks by the insurance industry, business interests, some of our even large health systems, and the right-wing think tanks. They just produced an article this week that said that 91% of New Yorkers really are quite satisfied with their health insurance. Well, I don't think that is an accurate representation. So we need strengthening, more people, more money for the campaign for New York Health. And indeed, universal, affordable, guaranteed, sustainable healthcare, where everyone is covered without financial barriers, lower drug and equipment prices, no unnecessary wasteful spending, and planning and control of future costs. Well, let's just do it. And here you see back in 2019, when we went up to Albany, a whole group of doctors and really strong supporters of moving to Medicare for all in New York State. So what can you do? Learn more about single payer reform. Go to our website. Contact our local activists, particularly the Campaign for New York Health. As you can see, that's nyhcampaign.org. And you can sign up to be on our New York Metro PNHP listserv. And finally, these are some contacts and references that you can use. One of the most interesting ones is this one that was just reported last week. In Lancet, an article that really looks at public policy and health during the Trump era and shows how single payer really solves the problems. So let me stop there and be open for your questions and comments about this approach to healthcare reform.
Thank you, Dr. Fein. Again, this is John Linder. I'm the co-chair of the Social Justice Action Committee with Ben, who's my other co-chair. Thank you so much. This was really, really interesting and lots of great facts and figures. We will try to get this, we'll try to get your PowerPoint and be able to share it to the Social Justice Committee. And like I said, we are recording this, and so we'll actually be able to put this up for folks to listen to. We want to open it up to questions. If folks have a question, you can raise your hand in the participants panel. You click on reactions and then raise hand. If you feel shy and don't want to talk on camera, you can type a question into the chat and we will answer it. And we did have a few questions from folks when they were registering. So Dan, I'm going to turn that over to you.
Sure, thanks, John. So I'll get us started with one question that was submitted. Actually, this was submitted a couple of times. I think it's been on a lot of people's minds. And the question is, can you address concerns which people with healthcare have about losing benefits if we switch to a healthcare for all system? Many times opposition views promote death panels or wait lists for regular procedures, and disincentives for such a system label it as socialized medicine, which I know you partly addressed. Basically, how does the system become a win-win for all and not a lose for some and a win for some others?
Those are very good questions. And, you know, I think there are a variety of ways of kind of addressing those questions. Number one, if we really have a single payer system where private insurance is not permitted to duplicate the public coverage, then what you have is a system that all the legislators in the country and the president would all essentially have the same system. And I think we would want to see that system cover very generously everything that needs to be covered. Now, what about those waiting times? You know, you hear about that in Canada, you hear about that maybe a little bit in the UK. And that's an interesting question. There is, I think, total agreement that there is absolutely no waiting time for emergency medicine. Emergency medicine is dealt with rapidly on time, both in the UK, Canada, Germany, France, you know, Denmark. It's not a problem there. Sometimes it comes down, particularly I think in Canada, the most cited area where there may be some waiting is around joint replacement, knee replacement, things like that. And I've thought about that, you know, a little bit, because in my clinical practice, you know, it's very, very interesting. You know, I have a patient who I think should get a knee replacement, but most patients don't want to do that right away. They really don't. Well, if I were in Canada, I would put that person, when I thought they should get the knee replacement, on a waiting list. And sure enough, within a period of a year and a half or two, frequently then the patient is ready to go and get the knee replacement. But statistically, they've been reported as being on a waiting list, but not really. So I think that there are many things of that nature that sometimes magnify the reports that there are waiting lists in other, you know, total universal coverage countries. So those are two ways of looking at this. Emergency care, definitely no waiting time. And sometimes with elective procedures, there may be some degree of waiting time.
I'm just going to stop sharing your screen so we can all see each other again, if that's okay.
That'd be great. I like that much
I was going to
better.
say, I mean, I have to go see I have to wait to see a pulmonologist, for some period of time. It always just takes, it's not like, I feel like that's something we do already. We just don't
I
call it
say
waiting
that's
time.
true in the United States as well.
Yeah.
Very real problem, for access to specialty care and things. Even the primary care physician doesn't always have an open space.
Yeah. There's a series of questions that came into the chat box, and one, what do you think? And I actually want to call attention to Anne's question about Governor Cuomo's response. What do you think what do you think his reaction will be, and then what can we do to pressure him?
Well, who knows, really? He has said, that he favors single payer. But he thinks the only way to do it is to implement it nationally. Now, he might change his mind if, in fact, the issue would be that he had to veto legislation put forward by the legislature. Then he might even not be successful because we do have a little bit of a supermajority now in the Senate. So he might wisely just decide, okay, if the legislature passes this, I'll go ahead and sign it. And what can we do to encourage him? I think mostly it's really getting our representatives in the Senate and the Assembly to continue to maintain a strong position about favoring the New York Health Act. Because there's going to be a lot of pressure on them from, the insurance industry, the pharmaceutical industry, lots of money there, and also from some businesses and health systems.
Thank you. Fran, it looks like you have a question.
Yes, Dr. Fein, if single payer was implemented at the state level and not the federal level, I guess I have two related questions. What about the portability of the state health insurance if one travels, moves or whatever? And secondly, would Medicare recipients continue to be covered by Medicare, or would the state system be substituted? In which case I have the same question. What happens to portability and what happens if you move out of New York State?
Yeah, very good question. Very good question. And the legislation, as I understand it, deals with that issue. Medicare would be incorporated into the single payer system in the state. And if you were somebody who went down to Florida, got sick down there over the winter time, you would still be covered by the New York State plan. The New York State plan will, however, probably also be somewhat the way Medicare is. You do not have coverage with international travel. You would not be covered outside of the United States. And, if you're a person who does a lot of international travel, what you would probably do is buy a supplemental private health insurance policy to cover that kind of care. But if you're in the United States, the New York Health Act, as I understand it, covers you in other states as well.
So if I'm on Medicare now, and I will no longer be on Medicare because I'll be covered by the State Act, and I move to Florida, period, I'm just no longer a resident of New York State, what happens to my Medicare?
Yes, well, if you're no longer a resident of New York State, you would get your Medicare back, essentially.
Okay, you can reinstate it then.
Reinstate it, yep. Mhm. But those are good questions. No question about it.
A question from Emily in the chat. Is there any plan to train coders and other administrative personnel who might lose jobs in this system?
There's a lot of concern about that. And so there is a job retraining component in the legislation in the New York Health Act. There is also such a thing in the national bill. So there is concern. We don't want to see, healthcare reform creating increased unemployment in the country. So, even I think one aspect of Gottfried's proposal, and I'm not sure it would take care of all of the people that might lose their jobs, but this idea of a health, coordinator, somebody who, helps you find care, is, it seems to me, a possible kind of job that somebody who was doing billing and coding might actually be trained to do. So there is a little bit of ways to do that. Will it entirely cover everybody? We don't really know. It's not been easy to find out exactly what the size, of those, employees are who do a lot of administration. And I will say that probably a substantial number of them actually live both outside of New York State and maybe even outside of the United States. A lot of billing is done, in England and Taiwan and places like that. So other questions?
There's several actually in the chat. And I think actually one that is interested, the fee for service with doctors, would it still be allowed under the system? And I think along with that, given the sense, the idea that these are nonprofit systems, what does that mean for doctor salaries within hospitals?
Okay, well, number one, nonprofit hospitals are, as you know, not a big problem in New York State, because in fact, we don't allow for-profit hospitals in the New York State. That's interestingly against the law in terms of hospitals.
I did not know that.
Pardon?
I didn't know that.
That's
cool.
Yeah. Now, it turns out that dialysis centers are incorporated frequently separately from hospitals, and virtually 80% to 90% of those are for-profit. There are some nonprofits there, but I think what we'd like to see is that those be forced to, in fact, convert to nonprofit status. And nursing homes also very much in that category. They are for-profit entities frequently, not always, but we'd like to see them become nonprofit. Well, what about doctors? Well, one of the reasons why I think we've talked about them being reimbursed on a fee-for-service basis is that that isn't the most profound transformation for them. I might favor in certain specialties that we didn't actually do a strictly fee-for-service approach, but much more, for instance, in psychiatry, I think it really has to be more by the amount of time that you spend with the patient and so on. So there would be many things, I think, that would still be negotiated around how physicians, nurse practitioners, other health workers would be reimbursed that aren't at this point explicitly stated in any legislation. So that's something that would really need to be worked out in the future.
And are there other questions from the list that we were sent ahead of time? I want to cover some of those too.
I think everything sent ahead has been addressed. I'm checking really quickly.
And there are still a couple more questions in the chat function.
Good.
Sorry, who said?
And
All right.
There was a question in the chat about the CEOs of the insurance companies. Can that somehow be rectified with this system?
Okay, the CEOs of the insurance companies would not exist anymore.
Wouldn't that be nice?
Right. I mean, their unemployment we're not worried about at all. They will be, essentially relieved of their responsibilities and their incomes. Now, insurance companies aren't going to go away. That's true. And I talked about, having private insurance supplement the single payer coverage, but not for anything that's covered by the single payer coverage. So for instance, private rooms in a hospital might be something that some people would say, oh, I really want to have that. And well, that might not be covered by the single payer. Well, you could get private insurance to cover a single room in a hospital, unless you have a reason from the medically necessary reason to have a single room. You have tuberculosis. You're coughing away in your room. Get me out of your room. You deserve, your own single room. You have a bone marrow transplant and you are immunosuppressed. You need to have your own room. You cannot be in a room with someone else. So those would be covered by the single payer. But you're somebody who just wants to have your own room. You could go out and buy health insurance, that would cover that particular benefit. So insurance companies aren't going to go away. Most of them, also deal with automobile and home and other things. So I have, but these really very high earning CEOs just should not exist.
So one other thing is the funding. If it's just New York State, the funding would come from what you said, from the employers, and some of it through the employees themselves. But what about the retired people like ourselves? I mean, like a lot of us that are getting the Medicare because we paid into it for so long. So would we still have to, well, we're paying taxes on that anyway. But
well, you would be your Medicare money, the money that in fact, would be used to cover your care, is what would go into the trust fund. It does require a particular waiver from the federal government to allow that to happen. But that's not something that's so impossible to do. The same would be true for Medicaid. That Medicaid, there would be a waiver, and that the New York Trust Fund, Health Trust Fund, would get a certain amount of federal money to, to cover both the Medicare and Medicaid beneficiaries.
it was my understanding that all that money that came from the feds now goes to the state already, and for dispersion.
Well, for Medicaid,
But Medicare too, no?
not Medicare. Oh, no. No, Medicare, is something that is negotiated with each hospital and the federal government, for instance,
Okay.
or each doctor's office. There's a whole, you know, if in my office, if I'm seeing a straight Medicare patient, my office bills for that patient to the federal program.
We have two hands raised, James and then Fran.
Hey, great talk. I really appreciate it, Dr. Fein. I've actually seen some of your talks at SGIM, and yeah, appreciate all the great work you're doing in
My
this space.
God, really?
Um,
SGIM? How,
yes.
Are you a doctor?
Yeah, I think we've met at one point. I was with mentee of Jerry Passione, and so I'm
Oh, yes. Uh-huh.
currently I'm curious as to your take. So I currently work in correctional health single payer system, and I love it. But I also am faculty at NYU Langone, was previously faculty at Montefiore, and I'm curious as to your take on academic medical centers and their like perspective on this, because I see the differences between I work at Bellevue and then there's Tisch, and the different way they kind of run these like separate corporations. And I'm curious as to like your take on how supportive they are of single payer, and like, or if it's variable between them, and like advocacy within academic medical centers in this space, like what your general sense is to where that's going.
Yeah, very important question, actually. And my sense is that's why I said earlier that there are some health systems that I think will struggle very strongly against going in this direction.
Yeah.
And, I actually had a student this past year who decided his project was to interview hospital leadership around the New York area. And what he found was that, a lot of people in the big systems, such as, Mount Sinai,
Yep.
Columbia, Northwell, probably are not in favor of the New York Health Act.
Yep.
Whereas people in the Health and Hospitals Corporation and people who were in private hospitals that were actually in, Black serving or Hispanic serving neighborhoods were much more positive toward what the New York Health Act would do for them. I mean, that those hospitals would really be able to do much better than they presently are.
Yeah.
So that's, I think, another area of important concern. And I think that we have to really work on our systems not to put up so much resistance. They're being cautious about doing it right now, to be honest.
Yeah.
So we'll have to see. We'll have to see. And just for everybody else, SGIM, what is that? The Society for General Internal Medicine. I'm a generalist, it turns out, and James must be in some ways a generalist as well.
Yep.
And this is a group that we formed actually back in the 1970s to give people in academic health centers who were generalists an organization that was struggling for them. The other very interesting fact that most people don't realize is family medicine, which is also a generalist specialty, so to speak, didn't exist back in 1970. It was only created in the 1970s and early 80s. And the result is here in New York City, there are no family medicine departments at Columbia, Cornell, and NYU. There wasn't any at Mount Sinai until 2 years ago when a group called the Institute for Family Medicine decided to, in fact, become a department at Mount Sinai. So generalism has struggled to get recognition in the academic health center.
I'm going to call on Fran to ask her question. Then we have one more question from Maria in the chat, and that might be a good stopping point.
And then I actually have one more question after that.
Oh,
No, I think we know where and how to advocate for a single payer, but it seems to me that that really is a longer term solution. And what can be done in the interim to meet the immediate healthcare needs of many people? Are there any legislative or administrative actions that are pending that deals with the situation we have now? I mean, are there fixes to the Affordable Care Act? Are there things we should be focusing on and pushing to take care of the needs of the under and uninsured right now?
Well, it's a good question. Pramila Jayapal and Bernie Sanders actually did make a case for and created a piece of legislation in which they said there should be an emergency Medicare for All Act for anyone who had become unemployed and had no health insurance. They should be able to apply for Medicare. And that legislation, of course, under the Trump administration and so forth, never got passed with Republican control and so on and so forth. So, you know, that's difficult. Expanding the ACA is a mixed bag. The Affordable Care Act, you know, predominantly the majority of people who got health insurance through the Affordable Care Act got it through Medicaid, expansion of the eligibility on the Medicaid program. Prior to the ACA, even in New York State, which was judged to be a very generous state in terms of Medicaid, if your income as an individual was essentially above 90% of the federal poverty level, you no longer were eligible for Medicaid. The ACA brought that eligibility up to 138% of the federal poverty level. And as a consequence, about 1.5 million New Yorkers were able to get onto Medicaid. So that's just an interesting fact to know about. And the other side of the ACA was that you could get private health insurance through what are called exchanges that would be subsidized by the government. Okay, so if your income was above 138% of poverty and less than 400% of poverty, you could get private health insurance with federal subsidy for your premium. But, you know, that just seemed to me to be backward. It was a way probably to get the private health insurance industry to not oppose the ACA, right? Because here you had a law that mandated that everybody in the country had to show on their W-2 form when they file taxes that they had health insurance. And if they didn't show that, they would be paying an additional tax. But to actually put money into people getting private health insurance just seems to me to be backward, because that's what we have to eliminate. We have to really get rid of the private health insurance industry. So I don't know if that kind of answers that question for you, Fran, but I think it is a significant set of issues. No question about it.
Yes, thank you for that. It's important.
Did you want to touch on this question, Ben, to Maria, or no? I can't remember if we've already.
Sure. Yeah, I'll ask that question. The question is, will this system make it easier for students to become doctors, or will the AMA still have leverage in keeping the number of doctors low?
Well, that's a very, very interesting question. And what literally controls the number of people who can become doctors? You know, we have a system in which the number of medical school graduates is much less than the number of residency positions that are open in the country. And in order to practice medicine, you do have to go through a residency. You know, in internal medicine, 3 years, in surgery, 5 years, and so on. As a consequence, as you know, probably you've experienced this, who do you see but a lot of foreign medical graduates, what are called foreign medical or international medical graduates, who come to the United States to do residency training and then stay here, right? So you're absolutely correct that what's happened is that there has been a tightening of the number of US medical graduates, and the AMA has been really very much behind that. And one would hope that actually if we went to a universal coverage system, we could really, you know, counteract that AMA emphasis and increase the number of US medical graduates, and not rely, as we do presently, frankly, on international medical graduates. Many of whom, by the way, are wonderful people and do a wonderful job. But I think that's really, you know, again, robbing other countries that frequently need those people as well.
Okay, so that I'm going to close it with sort of a question and a half. The first question is, what is our, I don't want to say talking points, but like, if somebody, I think the common argument about this is, oh, it's going to cost me more. Can you just give me the quick, like 30-second, if somebody asks, like, I'm paying this much money through my employer for insurance here in New York, and I'm specifically the New York Act, what's the counter to that? Like, what's it going to cost me? All of that. And you referred to it, but I wanted to sort of have a succinct answer to that. So when people ask us what this was about, we can say, oh, it's about this act, and we want, you know, here's what it helps us do, and here's how much it'll save us.
Okay, well, I think what one says is that, you know, there have been all sorts of studies done of the US, of the New York Health Act. And it is true that the majority of those studies have said that it's going to cost more money. But there are also those studies by economists and by groups like the Rand Corporation. As I said, this is not, you know, a left-wing group by any means, that show that we could save money if we went in the direction of the New York Health Act. And not by covering or cutting back services, frankly, but, you know, by having a more efficient system, not having to deal with the overhead, the huge overhead that comes because we have multiple for-profit private entities out there, both competing and controlling the healthcare system. So my sense is that one just has to say that that's the case. You know, that yes, there are conflicting studies on this, but that there are many good studies that suggest that we can save money.
And if I had an employer covering my health insurance, those premiums would instead of going to a private insurance be going to the state, plus a progressive tax for people that based on their income would be paying more for their insurance versus other, but still would be less than what you're probably paying.
Definitely, yes. It would definitely be less than they're currently paying. Exactly. And, you know, I think even the businesses might end up benefiting by having a tax that is lower than they're presently paying for private health insurance premiums.
No, I mean, I've worked in the nonprofit field for a long time, and you know, the smaller nonprofits tend not to be able to bargain very well. And so we'd have 20% increases on our health insurance premiums from year to year. It's hard to budget when it comes down to it.
Exactly, very difficult.
And then, so I think the last question is our next, so March 9th is the sort of the prep session for the lobby day. I think that sounds like it's a good set of actions for us to, as a community, to be able to get behind and support.
Yes, definitely. And it will be a virtual training session.
Okay.
So it's something that you can come essentially again on Zoom and be engaged with, you know, a training session. It's not going to deal with the details of what's in the legislation, but much more with, you know, how to actually speak to your legislator about, you know, a universal coverage system. And there'll be a great deal of interest in, you know, what legislative district you come from, so that you can in fact be paired with a group of people that would go to your legislator essentially and be able to talk about the New York Health Act.
Good deal. I think with that, I don't want to take any more of everyone's time tonight. Fran, Ellen, do you want to, I just want to say thank you both for organizing this. Dr. Fein, thank you for being here tonight. This was really, really helpful. And it's exciting. We have something, you know, we have things that we can do now as a community, as a committee to make this better.
Absolutely.
Okay, all I want to say is thank you very much, but would you encourage us to write to our state senators and, you know, kind of like pressure them to pass this along?
Yeah, absolutely. I mean, two things, you know, number one is to find out who your state legislator is, and then the Campaign for New York Health, right? Remember that?
Right.
New York NYH campaign. They will know whether your legislator has signed on, you know, to the piece of legislation as an advocate for it.
Right,
or
right.
not. So
Well,
that
the thing is
when
that-
you write your letter, you
Yeah.
can be more specific.
Right. We do know who our legislators are, and they have signed on.
Yeah.
So can we write to other ones, I'm thinking?
Well, that's possible, but don't also write to the ones that are on that may have signed on, telling them, you know, you really have heard more about this. You're so happy they've signed on to it. You want them to continue to advocate for it.
Okay, no, good. We can do that.
Yeah, absolutely.
Yeah.
Thank you. And I guess with that, we will probably see you on the 9th. And we'll be sharing that information to our lists and all, so pay attention. And like I said, we'll get this recording posted so you can share it with friends who want to see it. And Dr. Fein, I'll get the presentation from you after the meeting.
I'll try to email it to you. Yes.
Thank you so very much.
Thank you.
Have a good night.
Thank you very
everyone.
much.
Thank you.
Okay,
Thank
fine.
you.
Thanks, everyone.
Bye-bye.
Bye-bye. Thank you.